Yeah, the Honorable Prof. Joko Kato, the President of ASEAN Congress of Neurosurgeon, the Honorable Professor Easwer from India, the Honorable Dr.Liew Seng from Malaysia, the Honorable Prof. Asra, Fauzi from Indonesia, Mrs. Dhanya Sasi from India, and all speaker. Good evening. I'm Enny Mulyatsih from National Brain Center Hospital, Indonesia. National Brain Center Hospital is the top referral hospital in Indonesia for neurological and neurosurgical cases. We have 3 speakers for this evening, and the first speaker is Professor Dr. Asra Fauzi from Indonesia. He will he will share about the management of subarachnoid hemorrhage. The time is yours. Or maybe at the first, Prof. Joko Kato would like to speak. Time is yours,
Okay.
Prof. Joko Kato.
Hi, welcome everybody. So today, unfortunately, Dr. E, Matrani is maybe on the way back from the Tanzania, I think.
Yeah.
So, but I think we have a gorgeous guest today. So maybe we are very much looking for your lectures. So our doctor and nurses who is from at our place joined already. Please start.
Okay. Thank you, Prof. Kato. So now, would you please, Professor Asra, it's your time.
Yes, I think Professor Easwer will be moderate.
Yeah,
Okay.
I'm moderating. Let me also give
Sorry.
yeah, no problem.
Yeah. Okay, Professor, please.
No, I was very impressed by the CV, the biodata or the curriculum vitae of Professor Asra. He has, almost a year senior to me, and he has been on some of the best places. He has been trained in Japan, in South Korea, and the United States, and he's an authority on cerebral revascularization procedures. Also, he does a lot of work, non-neurosurgical work too. And I understand that he has a degree in management too. Publications over 100, and he has a chapter on every subject, textbooks galore. I think I'm happy to be sharing the space with Dr. Asra Al Fauzi, who incidentally works at the Dr. Sotomo Hospital in Indonesia. And interestingly, it's a physician turned and also a nationalist. The hospital is named after Professor Dr. Sotomo, who is a nationalist and a physician who's a national hero of Indonesia. I think over to you, Professor Al Fauzi, for your wise remarks on subarachnoid hemorrhage.
Thank you, Professor Easwer. You know much about Dr. Sotomo. We are very delighted. He's one of our heroes. The doctor also, a hero in our country. Also, Professor Yokato, thank you for your always effort for us, and my friend Liu and Dhanya, and also Kabulo, and of course, Bu Enny Mulyatsih. Yeah, he's my partner in Indonesia. Okay, I will share my presentation. Okay, you can see my slide?
Yes.
Yes.
Please.
Okay, thank you. Okay, thank you. And it's a very honor for me to give a lecture about the aneurysmal SAH. And of course, I will try to present some basic management of aneurysmal SAH, especially in my hospital. And like Professor Easwer already introduced me that I'm working in Surabaya, the second city after Jakarta. Enny stay in Jakarta. So, but we have some the same interest, and Enny always, have some collaboration with some program with me. Yeah.
Thank you.
Yes. Yes. We already know that subarachnoid hemorrhage is, I mean, non-traumatic SAH, usually caused by a rupture of intracranial aneurysm that sometimes not only associated with intracranial pathology such as sudden increase in ICP and also global ischemia, but also we will, dealing with some systemic complication that usually make the prognosis is worsening in our patient. So SAH always challenges for us, especially neurosurgeon. And recently, many publications, including the International Spinal Aneurysm Trial, ISAT, there is some, shifting paradigm of the how we should manage the definitive treatment of cerebral aneurysm. That endovascular embolization is now getting popular among the center young neurosurgeon, so they want to learn much about this kind of procedure. But we are neurosurgeon, we should treat endovascular that we can do both treatment, open surgical clipping and also endovascular embolization. Yes, this is some data. I will show you about the incidence of SH, 9 per 100,000 person in some regular variation. And this also, I think, Professor Yokato know much about it, that in Japan and in Finland, the incidence is higher. So that's why many young neurosurgeon, if they want to study aneurysm treatment, so it's easier to to go to Japan because they have many cases. And but interestingly, that the prevalence of intracranial aneurysm is not found to be higher in Japan or Finland, but the risk of rupture is higher. So we know that they have some in Finland and Japan, they have some maybe specific guideline that may be a little bit different with the other, because they have tendency to get more rupture than the other part of the world. Yeah. WHO Monica stroke study reported that 30-day case fatality rate of 42%, and another study from Australia and New Zealand placed 28-day case fatality rate at 39%. And also the risk for permanent disability is high among survivors, and the dependency rate is approximately 50%. So this is a global burden for a stroke patient, especially with SAH. So we have to manage this patient optimally, so we can reduce the morbidity and mortality. Yeah. So especially for aneurysmal SH problem, currently 2012 report that aneurysmal SH is a significant cause of morbidity and mortality throughout the world. A quarter of patients with SH is die, and roughly half of survivors are left with some persistent nasal deficit. So this is a very interesting data that many of even they survive, but they're left with persistent neurological deficit. Interesting data suggests that early aneurysm repair together with aggressive management of complication such as hydrocephalus and DACI is leading to improved functional outcome. So even with surgical management, so we should treat medical management optimally, because the complication of the subarachnoid hemorrhage is very broad spectrum. So even we sometimes successfully treat the patient with endovascular recoiling, but with after the treatment, we should treat the patient in good management, especially how to prevent such as delayed cerebral ischemia. I think this is a basic one. We should know that actually most common cause of subarachnoid hemorrhage is head trauma. We already know that, and we are talking now about the aneurysm. Cerebral aneurysm is the most common non-traumatic cause. Yeah, of course, the treatment of the ACH between the trauma case and this non-traumatic case is very different. The other etiology, we can see some dissection, perimesencephalic hemorrhage. Maybe we have some experience to have a patient with this kind of hemorrhage, amyloid angiopathy, and some coagulopathy disorder, vasculitis, and drugs, especially sympathomimetic drug. Yeah, we together about that. But this time I will talk about the cerebral aneurysm, the etiology of SAH. This is I think we should know about this too, because we can decide the best treatment if we know the risk factor of our patient. So risk factor for development of aneurysm, we can see hypertension, smoking, chronic alcohol use, and also family history of intracranial aneurysm. And also the risk factor for rupture of intracranial aneurysm is female, Japanese and Finnish descent, smoking, hypertension, drug abuse, and posterior scleral aneurysm. We should know about this too, and of course the giant aneurysm. Yes, this is also very important to know among us, that the earlier we diagnose this is a cyberhemorrhage, so the earlier treatment is better for our patient. Yeah. Most aneurysm remain undetected during one's lifetime or until rupture. An aneurysm is often an incidental finding during investigation for other causes of intracranial pathology. Maybe like in my country, Indonesia, I think is maybe the facility in the situation is very different. I think in my experience, maybe more than 98% patient came to our hospital to me is in rupture case. So very small number of unruptured case. So this is one of our problem in my country. And the brain screening is not covered by insurance yet. So sometimes it's not easy to get patient to find with the incidental finding about some pathology in the brain. Yeah, this is our problem. Yeah, so most of cases is come with with a rupture case, and some patient we cannot go further for definite treatment because the condition is very bad, and only maybe 1 or 2 days died in the ICU, or sometimes they came with bad condition, so we can do some some further treatment. Yeah. And clinical presentation, always we can see the word that worst headache of my life. Yeah, this is a thunderclap headache. Is usually the first symptom of aneurysmal supine hemorrhage. Yeah, but sometimes the headaches are often accompanied by vomiting, photophobia, decrease of consciousness, and even coma, and also nuchal rigidity and a focal neurological deficit. Yeah. Yes. We know that the diagnostic modality of subarachnoid hemorrhage because of aneurysm rupture is very variation is available in the hospital. But for subarachnoid hemorrhage, so head CT scan is very sensitive. So every patient, I think we have CT scan evaluation, and more than 90% we can detect this as SAH cases. For small cases, I think lumbar puncture we can perform this too. If we high consideration if this patient is clinical presentation with SH, but the head CT so not very specific of the SH. Yeah. So we can see some RBC, red blood cell, and xanthochromia in the GSF. Yeah. Also, we can from CT angiography, MR angiography. MR angiography is usually very advantage for brain screening, because sometimes it didn't need a contrast. Yeah. And also the golden for if especially if the patient prepare for some procedure, I mean maybe surgical clipping or endovascular coiling, so DSI is mandatory. So this is the gold diagnostic, yeah, for diagnostic of cerebral aneurysm. Yeah. So I think all the doctor in emergency room, nurses, and maybe young doctors have to know about this assessment of the SAH, yeah, because this hand and case grading, WFNS grading system for AAs, and also visual grading is very important, because this assessment correlated with further treatment. Yeah. For example, if the patient with came in our emergency room with a deep coma or hand enhanced grade 4 or 5, so sometimes we only did some stabilization in the neuro ICU and put some medication supportive, yeah, because the prognosis is very bad. So, and if the patient came with a good grade of hand and hair, so we are prepared for aggressive treatment, for definite treatment. Yeah. So this is very important. Yeah. I will show you some proposed guideline of HH from NAFERT in 2020. You can see in this slide that for detection of aneurysm, so we can use CTA or DSA. Yeah. But sometimes, especially Indonesia, sometimes DSA is not available for emergency care. Yeah. So sometimes we use CTA first, and then sometimes we perform surgery or endovascular treatment with the CTA. But if it's available, we can use DSA. So we can wait for tomorrow morning or something like that, and then we decided which is the best to treat between the endovascular coiling or surgical clipping. Yeah. So you can see that, yeah, that sometimes if there is non-aneurysmal perismatic matter or no SH on CT, but positive L lumbar puncture, so Neifert et al. Suggest to use CTA to investigate the cause of the SH. Yeah. This is the very important issue that we have to discuss today. That maybe I will present about the four complications that's important for us. There's also systemic complication like NPA and cardiac complication and hyponatremia. But I will focus on this four of complication. You can see rebleeding is, very, very danger if we not try to prevent this here, because the second bleeding increasing the mortality 20 under 20%, and 3 and 15% in first 24 hours. So usually in my hospital, we try to manage definitive treatment in 24 hours. But sometimes because the facility, it takes maybe 2 hours, 2 days, yeah. But we try to manage our acid patient in 24 hours for definitive treatment, yeah. And also the vasospasm, yeah. Yeah, because if we not if we not treat this complication earlier, so the patient will fall in ischemic stroke or delayed ischemic nodule deficit. Yeah. Day 3 and 5 and peaks day 6 until 8, complete resolution until day 14, but windows goes to 3 weeks. So there is some protocol that we should give the nimodipine until 3 weeks. Yeah. Seizure, yeah, we should prevent this because if happen, it's worsening the functional outcome. And it's also hydrocephalus, 25% in first 48 hours. So sometimes early acute hydrocephalus, it's happen in SAH, but the other will happen in chronic phase. Yeah. Yes, this is very important, especially for for nurses and for doctor that work in emergency room, that always stabilization, airway, breathing and circulation, and head CT scan is mandatory always. Laboratory, especially if we want to know if there is a etiology of coagulopathy or diabetes and other that make a worsening of our patient. And ECG monitor, as you know, that is one of the modality to treat earlier our patient, but actually it's not it's not in my hospital we not use this regularly. And for high pressure, high blood pressure, so the goal yeah, in my experience, I use around 150 until 160. So because it it prevent vasospasm complication, but if too high, so the complication of rebleeding also will happen too. So we have to treat the blood pressure with ideal measure, yeah. And also earlier consult to neurosurgery team, yeah. And if there is acute hydrocephalus, so we should report this finding too, because we should treat this aggressively in acute care. So this is the very important too, that sometimes our resident should know about this before, maybe in a couple of hours going to the operating room or going to the cath lab, yeah. And how we should securing the aneurysm not to rebleed, yeah. Prevention the rupture, avoid straining, avoid falsava, treat pain with analgesic medication, antiemetic, and antifibrinolytic. Maybe some literature so reported that antifibrinolytic treatment is not very useful for securing the aneurysm, but some doctor and some hospitals still use this kind of drug, yeah. And of course the managed blood pressure. Yes, this is in an issue too, that we should you know decide the best treatment of our patient between coiling or clipping. So in my hospital, the neurosurgery team, we have a team with expert in endovascular, and the other expert in open surgery. And many of my younger staff, they can do both. So yeah, and it's easier to to discuss whether it's better, whether it's best for our patient. Yeah. So yeah, this is some condition that maybe basic basic criteria that we can use to choose which is the best definite treatment for our patient. Certain aneurysms are not suitable for endovascular clearing, such as giant aneurysm, wide neck aneurysm, fusiform aneurysm, aneurysm at certain anatomic location, for example, in MC aneurysm, yeah. And also if there is a rupture aneurysm with mass effect, intracerebral hemorrhage. So sometimes it directly goes to open surgery, clipping. Yeah. And also certain aneurysms are not suitable for surgical clipping, such as deep location, basilar aneurysm, intracavernous ICA, posterior aneurysm sometimes, and patient with comorbid condition, and also with a patient with massive brain edema. So this is some guideline for us to choose which is the best to our patient. For example, this is a case of a posterior pica aneurysm that we decide to to treat with the endovascular coiling. So the other, this is a case of rupture become aneurysm. I think this is the movie. Okay, yeah. So we can see, I think, quite wide neck here. So we choose the clipping procedure in this patient. So yes, now you can see that posterior projection of the dome. You can see the neck and aneurysm, and yes, just the clip to obliterate the neck of the aneurysm. You can see many blood in sparring space, means that it's a rupture case with huge amount of the blood. So we irrigate and wash also this sparring space to clearance the blood. Yeah. So this is example of clipping procedure. And yes, this is our enemy too. Yeah. And until now, it's very, very difficult to treat. Yeah. DCI was defined as described by Vergoen as a decline in consciousness of 2 or more point of the Glasgow Coma Scale. Yeah. Or occurrence of few focal neurological deficit. Yeah. Lasting at least 1 hour. DCI is a serious complication of SH and is associated with adverse neurological outcome and may occur with or without vasospasm. The term DCI is preferred over vasospasm because cerebral ischemia can occur following SH without angiographically detected vasospasm. Increased risk with SAH thickness and also intraventricular hemorrhage. Yeah, so until now, this is some of the modality to treat our patient. Early detection of vasospasm we can do it in neuro ICU with transcranial Doppler of TCD, and we now use the nimodipine for orally, and the report of the many articles show that this kind of that reduce risk of poor outcome. Sometimes, if the facility is available, we can do cerebral angioplasty or intraarterial vasodilator with Tingkat-Dippel or Frapamil. Yeah. And always, the hemodynamic status of patient for euvolemia and also induced hypertension about 150 under 160 to avoid, the vasospasm. Yeah. So this is about hydrocephalus. So this is for from the new guideline from AHA in 2023 that you can see that in patient with aneurysmal SH, acute symptomatic hydrocephalus, urgent GSF diversion should be performed to improve neurological outcome. Yeah. And also, if our patient fall in chronic symptomatic hydrocephalus, so permanent GSF diversion is also recommended to improve neurological outcome. Yeah. And that's important too that routine fenestration of the lamina terminalis during surgery is not indicated for reducing the rate of sun dependency. So even we open the lamina terminalis, sometimes the patient still needed for VP-sun insertion. Yeah. Patient with SH are at risk of developing symptomatic acute. Yeah. For 15 until 87 in acoustic. Yeah. And lumbar drainage or of GSS after SH has been shown to reduce the prevalence of DSA and improve early clinical outcome. So you can here we can use whether lumbar puncture or AVD, but sometimes I use this determined by hemorrhage or hydrocephalus GSF flow pattern. For example, if the too much blood in the intraventricular, so I think the risk of blockage of our ventricular drain is higher. So I use the lumbar drain, and also if we think that the patient need more observation of GFF drainage before decision, which is patient will have some permanent VP-sun. So if we need some long-term observation, I use the lumbar drain because it's easier to manage to mobilize the patient. Yeah, yeah. Compare with the AVD. Yeah. And this is also about the, medication for prevention of seizure. You can see here that the patient who present without seizure and patient who present with seizure is very important to understand. So there is some indication that we have to, put our seizure medication in our patient, especially patient with SH and high seizure risk. For example, rupture MG aneurysm, high-grade SH, IC8, hydrocephalus, and also the cortical infection. So the use of prophylactic anti-seizure medication may be reasonable to prevent seizure. Yeah. And also, if a patient who present with seizure, treatment with anti-seizure medication for 7 days is reasonable to reduce seizure-related complication in the perioperative period. Yeah. So, and in patient with a SH without prior epilepsy who present with seizure, treatment with anti-seizure medication beyond 7 days is not effective for reducing future associated seizure risk. So this is the guideline from the American Heart Association, American Stroke Association in 2023. This is very important too. So my take-home message is first, acute rebleeding after initial SH is associated with increased mortality and poor clinical outcomes. Treatment of the rupture aneurysm are recommended, preferably within 24 hours. And also the balancing the goal of securing the rupture aneurysm with the risk of intervention is based on patient and aneurysm characteristics and should be determined by specialists with expertise in endovascular and surgical treatment. Medical or systemic complications in multiple organ systems are associated with worse outcome after SH. For new onset seizure after SH, treatment with anti-seizure medication for 7 days is recommended. DCI remains a significant complication and is associated with worse outcome after SH. Early initiation of enteral pneumothorax is beneficial in preventing delayed cerebral ischemia and improving functional outcome after ASH. And elevating blood pressure and maintaining a volume in patients with symptomatic delayed cerebral ischemia can be beneficial in reducing the progression and severity of delayed cerebral ischemia. And very important too that, we should have a multidisciplinary approach, yeah, neurologist, neurosurgeon, neuroanesthesia, and cardiology, and internist. Yeah, it's important in managing SA cases for optimal outcome. Yeah. So this is in my hospital. Yeah. This is my fellow and my colleague that doing mostly the endovascular, and I'm mostly doing the clipping surgery. But usually we work together in OT on in cath lab, and this is our the nurse that is responsible managing patient in cath lab, yeah, for endovascular treatment. Yeah. And this is our fellow. In my country, we are the hospital that first, have a fellowship program for vascular training in both in open surgery and in endovascular treatment. So it has been about maybe 6 years, and we have produced many young neurosurgeons, and they now working in many area in many island in my country, and yes, they doing a good job. Then they can treat both clipping surgery and the vascular treat. Yeah. Thank you very much. I think that's all for me. I hope you all have some new knowledge, yeah, benefit from my presentation. Thank you very much. Yeah.
Thank you, Dr. Asra Fauzi.
Yeah.
That was a very informative lecture for all of us. It covered a lot of the basic stuff that's required and some of the nuances that helps us to deliver better patient care. I would like to invite the commentators to offer their comments on this lecture by Dr. Fauzi. I think we have Dr. Liew, Seng, and Mrs. Dhanya as our commentators.
Yeah. Hi. Thanks, Prof. Asra, for very comprehensive
Thank
lecture.
you. Yeah.
Probably to start off, I may ask you two questions.
Yeah.
One is, what do you think the role of surgery among those patients with quite a diffuse or significant subarachnoid hemorrhage, especially fissure, probably with higher fissure grading 3 and above, or in patients who treated endovascularly? Do you think there any role of surgical management beside medical therapy? Secondly, what do you think that those patients now have been routinely undergo subarachnoid washout, whether those maneuver can actually help in reducing the risk of or the possibility of vasospasm, and then whether now we just purely dependent on the fissure grading to predict the possibility of a vasospasm in those patients, or beside intracranial pressure we should monitor for example the ratio, ratio, or any other advances, or some people may want to look into a brainwave, for example, in predicting and early detection of vasospasm. Thank you, Professor.
Yes, thank you, Dr. Liew. So about the management of a high grade, ACH in patient with maybe in not very good condition. Yes, there is some rule, I think, for surgery. For example, my case that I show you the movie, actually it's a high grade ACH patient, but he has he has a kidney problem. So I show you that he only get a diagnostic modality of MRA, not CTA or DSA. Yeah, so I directly goes to clipping surgery. Yeah, so there is some indication too. For example, young patient. Yeah, young patient. Yeah, even they have in a in a bad condition maybe, or in a high grade acid. But if we discuss with anesthesiology, and they can manage that quite properly, especially after the surgery too. So we goes to clipping surgery. And the third is, yes, of course, washing the subarachnoid is very important. Yeah, and if we can do it in early phase of the subarachnoid hemorrhage, maybe in quite several hours, it can a lot of benefit. Yeah, because we can wash the arachnoid hemorrhage. It's quite quite massively, and we should open the lilucus membrane, and sometimes indeed hours, sometimes 1 hour more. I use the the irrigation. I use the irrigation, and then if we see that the liquid is is more clear, so I try to stop and then continue with clipping. So it's that in Japan. I think Professor Yokato know that Professor Tanikawa.
Yes.
They use 2 hours only for irrigation. 2 hours. And need many liquid to wash the spinal space. and they suggest that it quite benefit for the patient, especially if they come in early phase of subarachnoid hemorrhage case. So I think I hope it has some benefit for you, Dr. Liew. Yeah.
A question that I want to ask the presenter is,
Yeah.
in poor grade subarachnoid hemorrhage, say at least the grade 4 or the grade 5 ones, do you think an initial trial of lumbar drain and washing away the CSF would help? Because I have seen some publications to this effect. Do you have any experience with it? In poor grade SH, to put a lumbar drain and wait for the patient to
Yeah.
go.
Yes. Actually, I'm not regularly doing the, just I already told Dr. Liew about washing the spinal speech during surgery. But we did the, lumbar drainage and also extraventricular drainage. But still the outcome is not very good. Even the patient survived, and we did especially endovascular treatment. The patient still have some, severe neurological deficit. Yeah. So that is a problem. Yeah, because the high grade SH usually, if we perform the CT scan, it's a massive brain edema. Massive brain edema, and later on they develop some, herniation and the vasospasm. Yeah. This is my experience, yeah. But we manage, optimally in our neuro ICU. But sometimes, definite treatment, is not very useful for this some patient. Yeah.
Thank you.
Can I say something?
Yeah. Please,
So
Prof.
hi. Thank you very much, Asra. So it's an excellent lecture. Thank you very much for very informative for all nurses. The recently Japanese treatment for SH is very, very simple till grade 3. So because we have a new drug, which is anti-endothelin, because endothelin is one of the biggest cause of the vasospasm. So we recently used the name is Pibrax. That's a very, very useful. Maybe I think the country still you cannot use.
Yeah.
I think.
Yeah.
So the endovascular treatment, and if the patient has a big hematoma, maybe evacuation with endoscope. So the endovascular treatment plus endoscope, that is maybe sometimes grade 5, grade 4, 5.
Yeah.
So I think endovascular treatment and sometimes with lumbar drainage and the drug of the Pibrax is now Japanese routine, and we can keep the patient not normal tension, normal volemia. So I think it's quite this very simple treatment now. Not so bad the outcome, I think. But you said very huge edema cases. It's maybe quite difficult to save the life, I think.
Yeah. Thank you, Prof.
Yeah.
Thank you.
I think the drug is only available in Japan, until now.
Yes, and maybe Korea.
Korea. Oh, I see.
Yes, extending a bit more and more by company, I think.
Thank you for the information.
Thank you.
Thank you, ma'am. I would like to invite anyone else who would like to ask a question to Professor Asra.
Can I say something?
Yeah.
First of all, thank you, Prof. Asra, for this wonderful session. So one thing that Prof. Kato said just now is very interesting. That drug is clazosentan, which is endothelin receptor antagonist, but this is not available in other parts. But very surprisingly, the drug nimodipine is not available in Japan. I wonder why it is like that. But the trials of clazosentan outside Japan are not so favorable, but inside Japan this drug has gained so much popularity. Like recently from the Nagasaki aneurysm registry, Professor Maeda published his series where he analyzed the pre-clazosentan and clazosentan and post-clazosentan era in Japan. So that drug has so much influence as of now that this drug is now now said to be like the standard of care in Japan, clazosentan. But coming to other parts of the world, it is very difficult to treat a post-SAH vasospasm. What we use in our place, what I have found very useful is a milrinone from the Montreal protocol that we use here in our setting. But I don't know what, I'd like to know what Prof. Asra used in his place in case of vasospasm or prevention of vasospasm.
Yes. So in my country, nimodipine or nimotop is the only available drug. Yeah. So we don't have the other drug. And we have nimodipine for intravenous and then also orally. So usually we treat our patient 7 days earlier with intravenous, and then for the other 2 weeks with pro-orally nimodipine. Yeah. So this is our guideline, yeah, in here, because the other drugs not available, Raja.
Right.
Yeah.
Thank you very much.
Yeah.
Can I ask a question again to the
Yeah.
audience? What is the role of steroids in poor grade subarachnoid hemorrhage? Do they really help? Because we don't have anything else to treat. We usually give steroids for all. Is there any evidence for that?
Yes, I don't think so. Yeah, so many reports reported there's not very beneficial effect of using steroid in some, especially SAD patient in very bad condition. So I don't know. Maybe you, Professor Yokato, have experience too. But in my country, we do not, use the steroid to treat the high or poor grade SAD patient.
So I think
Thank you.
that with my experience that the steroid is not so effective. Maybe sometimes effect for edema. So only that purpose.
Yeah.
Thank you.
Thank you, ma'am.
Sorry, can I ask a question?
Is there anyone else with a question?
I think
Can I ask a
Irfan
question?
wants to Irfan.
Okay, thank you very much. Thank you, Prof. Asra, from interesting presentation. My name is Irfan. Actually, I'm also coming from Indonesia. Now I'm studying in Totori University, neurosurgery department. So here my question is that it's very interesting. In our country, Indonesia, the patient seeking behavior is for the aneurysm always happen in the rupture stage. Do you have any suggestion or opinion or strategy how to improve this problem, especially for healthcare management or even for the young or future neurosurgeon? Because it is very interesting for me and surprising to see here in Japan, most of the aneurysm treated here is asymptomatic and they did very well brain screening. Thank you.
Okay. Thank you, Irfan. Yes, this is our problem, yeah, because before that, the brain screening is not covered by our national insurance policy, and our society, already make some suggestion to our Ministry of Health that we should try to moving our study to prevention, prevention of rupture than the curative treatment. So if we go to this direction, so the important thing is how we can do the brain screening massively. So before this protocol is established, then we should also get some suggestion to our Ministry of Health to increasing the facility of MRI in many places in Indonesia, because screening procedure, is better to use non-contrast MRI for screening. So this now is still going on, and Irfan, I hope maybe in the future the brain screening for prevention of or early detection of aneurysm can be performed and covered by our national insurance. Yeah, thank you for it.
Thank you
very much. Well, just I want to add some more things, because
Yeah.
unfortunately in Japan we have so many brain screen, brain check before rupture, and also additionally maybe you can check the visual imaging that tell us how thin of the aneurysm wall, or sometimes of course you can check the CFT. So those two things is very I think informative to prevent or predict the aneurysm rupture in the future. Thank you very much.
Yeah, thank you, Professor Kato.
Thank you.
Thank you. Can I wind up, Professor Kato? Can I wind up this?
But two more, especially one from nurse side.
Yeah, no. This session, the first session.
Yes, but two more questions.
Two more questions. Okay, please.
Please,
I'm not able to see the people who are asking.
Howard, please. Thank you very much for joining. Konbanwa.
Assalamu alaikum. Assalamu alaikum. Greeting. Thank you. Just I like to say I'm Dr. Ahmed Fauzi from Afghanistan, and excellent presentation. Thank you. We haven't possibility of operation for aneurysm in Afghanistan, and I like to know your advice for doing LP or lumbar puncture. Do you advise or not? Thank you.
Can you repeat? Can you repeat your question, sir?
He's asking about lumbar puncture.
For SH, do you advise LP, lumbar puncture?
For SH patient, yeah.
For SH.
Yeah. Yes. Sometimes I use the lumbar puncture for some indication. For example, if the patient also has a very huge intraventricular hemorrhage. So this if we put inserting the APD, the risk of blockage is very high. So I use the lumbar puncture. And also if we think that we need to make some long-term observation, I think it's easier to put the lumbar drainage, because lumbar puncture is for mobilization patient is more secure with lumbar puncture. So the APD is sometimes difficult to mobilize the patient. So that is some indication in my experience. Put some lumbar drainage. Yeah. Thank you.
Thank you. Shukran.
Yeah.
Sylvia.
Sister Silva, you have a question, Sister Sylvia? Sorry.
Yes. Thank you so much for such wonderful presentation. I'm the ICU nurse. Most of the time we have such kind of patient, but despite of the using a protocol, pneumotop and conversions and everything, within the 21 days, they normally have the severe headache, terrible, and so stressful for the nurse in managing such kind of patient. So how do you normally go through those patients in your setting? Thank you.
Sorry, can you repeat your question?
Okay, I say that I work in ICU, neuro ICU.
Oh, okay.
We normally have such kind of patient, but they always come with the aneurysm rupture. They kept in EVD with all the subarachnoid hemorrhage protocol, including pneumotop, and conversant, resting and calm environment, but they normally have severe headache before 21 days. How do you normally tackle them in your settings?
Yeah. In my hospital, usually we try to manage the patient for definitive treatment in 24 hours. So I think it's easier to earlier secure the aneurysm. So if you earlier secure the aneurysm, so the management after aneurysm is secure is quite easier. You can you can treat the for managing to prevent vasospasm with induced hypertension, so it is secure, and also to mobilize the patient, yeah, so it's secure not to to get rare bleeding again. So the important thing is for us is how we can secure the aneurysm earlier, so you can manage the patient safely after that in ICU. Yeah, I think that's all. Yeah, thank you. Yeah.
Enny, please unmute.
Okay, I think Prof. Easwer.
Yeah, I think we have no more questions. All questions over?
Yes.
Yes, okay, fine then. It was a wonderful lecture by Professor Asra Al-Faisi. A subarachnoid hemorrhage due to aneurysm is still a very unpredictable disease, fraught with outcomes which are not very favorable. And therefore, it is important that the neurosurgical team, which includes neurosurgeons, radiologists, anesthetists, and last but not the least, the nursing personnel, remain alert in their care for the patients by finding out what are the downturns early, especially in the evolution of vasospasm. We will be able to prevent poor outcomes. I'm sure that this lecture has helped us to learn more about it, so that our ability to serve the patients who come under our treatment is definitely improved. Thank you very much, one and all.
Thank you.
Thank you. Yeah. The next session, the nursing session. So, I would like to introduce two speakers from Indonesia. The first speaker is Elis Nurhayati Agustina. She get Master of Nursing from Indonesian University. She has experiences as clinical nurse and head nurse at stroke unit. And also she is active to educate nurses around Indonesia about the stroke care. And now currently she is a nursing manager at National Brain Center Hospital. Okay, Ms. Elis, it's yours.
Assalamualaikum warahmatullahi wabarakatuh. My honorable thanks to Bu Enny for the opportunity given to me. Good evening, everybody. Thank you very much to the committee for allowing me to join this event. I am very excited to be able to join the 13th Congress of Neurological Nurses. On this occasion, I will discuss about nursing care of the patient with aneurysmal subarachnoid hemorrhage. Maybe Nurse Risqi, can you share my PowerPoint? Can you show slide?
Yes.
Okay, thank you. Okay, next. Okay. Subarachnoid hemorrhage refers to extravasation of blood into subarachnoid space. Subarachnoid hemorrhage can occur due to traumatic and spontaneous, where 85% of the causes are aneurysmal and other causes are non-aneurysmal. Only about 2 to 7% of stroke, but 1/3 of sufferers die before arriving to hospital and high mortality and morbidity rates. Of those who survive, 50% are left with major neurological from initial hemorrhage, hydrocephalus, and delayed cerebral ischemia from vasospasm. The next. The high mortality rate in subarachnoid hemorrhage is due to complications. The most complication is rebleed, first 24 hours, day 7 and 10, and 30% hydrocephalus, first 24 hours after rupture. 39% vasospasm occurs at day 4 to 14 or 5 to 12 and peak on day 7. And the last, the complication is delayed cerebral ischemia or DCI. And the next. Nursing care for arachnoid, subarachnoid hemorrhage patient includes pre-operative and intraoperative and post-operative care nursing. The role of the nurse in preoperative is one assessment preoperative comprehensively covers bio, psycho, social, and spiritual. And the second is early detection complication like rebleed, hydrocephalus, and vasospasm. Until the damaged cerebral vessel is repaired, there is always a risk of rebleed. There are a number of ways an aneurysmal subarachnoid hemorrhage can rebleed, including an increased blood pressure or intracranial pressure, or for an unknown reason. Rebleed commonly occurs within 24 hours, the first rebleed, and hydrocephalus can occur through the blockage or obstruction in the reabsorption of CSF, or pathway are blocked with blood either from the initial bleed. The role of the nurse in intraoperative is detection complication like bleed, increased intracranial pressure during the operation, coiling, clipping, or craniotomy. The role of the nurse in post-operative is assessment post-operative, and the second is early detection complication like sign and symptom hydrocephalus, increased intracranial pressure. The next. The sudden and critical nature demands immediate and specialist nursing care to optimize patient outcome and minimize potential complication. Purpose the nursing care plan are early detection complication, preventing secondary brain injury, and promoting cerebral perfusion to support the brain's recovery. As for neurology nursing standard on subarachnoid hemorrhage is standardized nursing care for stroke patient has been shown to reduce length of stay, decrease rate of DCI, and positively affect patient functional outcome at 90 days. Nurse-specific competencies described include frequent vital sign, neurological monitoring, and IHSS assessment to determine the severity of the stroke, dysphagia screening, patient and family stroke education, monitoring for increased ICP and FED management. The next. Nursing assessment are carried out based on the patient condition. The assessment results that are usually found in subarachnoid hemorrhage patient are acute anti-severe headache, like thunderclap headache, and worse, Easwer headache, And sentinel warning headache. This is a minority, can occur days to week. And syncope, 50%, seizure 6 to 16%. And then decrease of consciousness, first from mild drowsiness and to coma. And the other is nausea, vomiting, neck stiffness, photophobia, and phonophobia. And then focal neurologic deficit may include intracranial hemorrhage or aneurysmal mass effect or post-ictal paralysis. And that nerve palsy with pupillary dilatation because compression nervous tree. 6 nerve palsy may false localizing sign representing elevated ICP and impaired upgas association with hydrocephalus. Dysphagia screening before initiation oral intake. This is a role nurse and IHSS score to determine the severity of the stroke. And the other is diagnostic examination with collaboration. And assessment of severity, subarachnoid hemorrhage, like Han and Hus grading scale or WFNS hemorrhage grading system. The next. The diagnosis or nursing problem that often arise in patient include rise or actual for ineffective cerebral tissue perfusion and decreased intracranial adaptive capacity, acute pain, impaired physical mobility, rise for infection, impaired verbal communication, disturbed sensory perception relate, anxiety, rise for impaired skin integrity, and rise for falls. And the next, several nursing action that can be taken into consideration in planning action that are tailored to the rise of complication, because complication can increase mortality. Nurses who are next to the patient for 24 hours must be able to recognize signs of complication and carry out nursing management. Nursing management for the rebleed is we have to study it about sign and symptom of rebleed include severe headache, decreased conscious state, new neurological deficit, and nausea and vomiting. We have to do neurological monitoring like GCS score, papillary response, motor function, and speech. As for frequency of monitoring, every 15 minutes, every 4 hours, and monitoring 48 to 7 days after rebleed. And then for the rebleed is environmental stimulus should be kept to decrease possible exacerbating factors, such which may lead to a rise in blood pressure and thus rebleed. This may include dark room or no radio or television or restrict visitors and strict bed rest. And then bowel and bladder care, such as stool softeners, are used to decrease straining, which may cause an increase in intrathoracic pressure and thus increases ICP. And then keep hemodynamic stability. We must to monitor and maintain stable blood pressure and administer prescribed medication. This is a decrease in systolic blood pressure to less than 160 millimeter Hg and ensuring strict avoidance of hypotension. That means arterial pressure less than 65 millimeter Hg. Blood pressure is closely monitored and active intervention is used to prevent hypertension episode. Okay. And then the next is nursing management for hydrocephalus. Early detection, sign and symptom, rise intracranial pressure, because hydrocephalus cause a rise in intracranial pressure that can result in nausea, vomiting, decreased conscious state, ataxia, severe headache, and alteration in neurological observation. A nurse must prevent rise in intracranial pressure, like head up 30 degrees. Frequent neurological assessment should allow for early detection of deterioration in a patient neurological state, which may indicate hydrocephalus, and prevent falsapa maneuver. Subarachnoid hemorrhage associated acute symptomatic hydrocephalus should be managed by cerebrospinal fluid diversion, like AVD or lumbar drainage. And don't forget to consult the neurosurgery. Nursing management of AVD prevent hydrocephalus. The next. This is nursing management for seizure. Isolate seizure are more common in patient post subarachnoid hemorrhage. And then development to epilepsy, but the patient can become the epileptic if the initial bleed or complication causes irreversible damage. Seizure is another complication that may develop directly or later after aneurysmal subarachnoid hemorrhage and may negatively affect the outcome of this patient, similar to the other complication. Seizure management, like drug, dose, timing is still controversy, but we have to do monitoring type, duration of seizure, ictal, and post-ictal is one of the nurse action for managing seizure. The use of prophylactic anticonvulsant may be considered in the immediate post-hemorrhage period. And the routine long-term use of anticonvulsant is not recommended by, but may be considered for a patient with known risk factor. Okay, the next. This is nursing management for vasospasm. Cerebral vasospasm usually occurs between 4 and 14 days post subarachnoid hemorrhage, peaking around day 7. Although it can occur much earlier, day 1, or later, day 28. So, as a nurse, we have to make sure early detection sign of cerebral vasospasm can include headache, inappropriate behavior, seizure, a possible alteration in conscious state, and change to neurological assessment. And then rise in blood pressure, and sign and symptom delights ischemic deficit. Commonly, sign and symptom of cerebral vasospasm relate to the particular cerebral artery involved and thus the area of the brain and the specialized centers it supplies. Euvolemia is recommended to prevent delayed cerebral ischemia. Routine hypervolemy is not recommended, and hypotonic fluid and volume contraction should be avoided. Administration of appropriate intravenous fluid at correct rate, monitor hematocrit level 30 to 33% optimum daily. Neurological observation, we have checked baseline blood pressure, pulse, and mean arterial pressure as stated before are done at least hourly before surgery to detect and treat any complication as early as possible. Medical therapy nimodipine, we must do monitoring dose, side effect, because sometimes nimodipine given over a long period. And then don't forget to monitoring blood pressure. The next. And this is the other nursing management for general issues of care include respiratory support, pain management, preventing infection, preventing skin breakdown, communication support, mobility support, anxiety reduction, and education to patient and family about a condition. And the next slide. Okay, I think this is the end of my presentation. I would like to summarize by saying nurse play a very important role for stabilizing a patient SAH. Do not only the insult of the initial bleed, but also the potential complication of rebleed, cerebral vasospasm, hydrocephalus, and seizures. Subarachnoid hemorrhage nursing care is carried out continuously from the pre, intra, and post-operative, starting with early detection through assessment. I sincerely appreciate this because I have this opportunity to present my presentation to all of you. Thank you very much for your great attention and good evening.
Okay, thank you so much for the great presentation from Elis. And now we go to the next session. The next speaker is Isnawan Risqi Rakhman. She is also graduate from Indonesian University, and he has experience as head nurse at emergency room and also at operating room. And currently, he is a nursing supervisor at National Brain Center Hospital. He is also the organization committee of Indonesian Neuroscience Nurses Association. And now time is yours, Risqi.
Okay.
You have about 10 minutes for your presentation.
Okay, thank you, Bu Enny. Good evening, all the professors, distinguished experts, and all the colleagues from ASEAN. And it is my honor to be here to present the case report about the subarachnoid hemorrhage. I'd like to present my case. Okay, this is the case reports, and I'd like to highlight about the understanding hemodynamic fluctuation in subarachnoid hemorrhage, a case report of brain infarcted patient after rupture subarachnoid hemorrhage. So this is the case presentation. Mr. B, 42 years old, arrived at emergency room at 7 a.m. accompanied by his family. Fell went in the bedroom for hours prior to arrival. And he complained headache since 8 p.m. or 8 hours before arrival with the neurological deficit, slight weakness, both left arm and leg, slurred speech, and asymmetrical face. No seizure reporting during transfer to hospital, and there is evidence of vomiting once. This is the clinical finding at arrival with the airway clear, respiratory rates for 14 per minute with the oxygen saturation 99% on nasal canal 3 liter per minute, and the circulation, the blood pressure is 170 per 100 millimeter of mercury, or the mean arterial pressure about 126. Heart rate 86, and the consciousness with Glasgow Coma Scale ICM-6 and verbal 4 with the pupil round shape and latch reaction good to the pupil latch direction good, and the motoric there is a slight left hemiparesis. Patient also has a knuckle rigidity and vomiting and headache evidence with a numeric rating scale about 8 to 9 with WFNS grade 3, dysphagia negative, and unfortunately not reported by physician nor nurses about the history of untreated hypertension before and risk factor including family risk factor. This is the laboratory finding. There is a slight leukocytosis. The patient got a leukocyte about 17,000 per microliter, and cardiac marker not obtained during emergency visit. This is a clinical finding at the arrival. The diagnostic study by the CT scan showed that there is intraparenchymal hemorrhage with a volume of 38 in the right frontotemporal lobe extending into the subarachnoid space, and also evidence subfalcine herniation and obstructive hydrocephalus. In emergency department, perform a CT angiography and show that there is a multiple secular aneurysm in M2 branch of the right middle cerebral artery with a size about 7 and two secular aneurysm found in the CT angiography. So this is the patient journey, nursing problem in the emergency room, risk for ineffective cerebral tissue perfusion, and the nursing goal is to maintain cerebral perfusion pressure. The patient get the medicamentosa ordered by neurologist, ketorolac, laxadine, and also given mannitol loading for 250 cc in 30 minutes. And also patient consulted a neurosurgeon for neurosurgery consideration. And after patient stabilizing in the emergency department on the day first, come to at 7 February in the emergency department, and patient transferred to intensive care unit prior to surgical clipping. And the day 2, patient performed surgical clipping and being taken care post-operatively in neurocritical care units about 2 days and continue in intensive stroke care units until day 11. After patient the clinical condition is stable, patient transferred to the wards, and patient discharged at the day of 16 of hospitalized. The post-operative medical instruction, this is the medicamentosa, and also patient, of course, give pneumotop, and also for the CSF diversion, patient perform lumbar drain setting at 10 centimeter of water. And also neurosurgeons advised to perform CT scan for brain evaluation. This is the conditions post-operative day 2 in the neurocritical care unit. Patient performed CT scan, and the results show that post-operative condition with right temporal bone defect. A clip was attached which caused an artifact in the right sylvian fissure accompanied by a hematoma ranit, and also found subacute infarction of the right temporal occipital lobe and right insula, and also still evidence of subfalcine herniations. And the infarct area expanded involving the temporoparietal lobe, insula, and the right internal capsule. Patient performed CT evaluation after extubated in the neurocritical care unit. This is the condition when the patient discharged to home at day 16th. In the 22nd February, patient discharged to home after being treated in the stroke ward. The patient consciousness is compos mentis with improving in motor deficit, and blood pressure is about 120. Headache still exists with the decreases of numeric rating scale about 3 to 4, and no evidence of seizure during hospitalized. We compared the clinical condition when the patient arrived to emergency department. So there is a clinical improvement, but patients still have deficit, neurological deficit, especially in hemiparetic, left hemiparetic. So this is the on the right picture is the CT scans show that there is a hypodense area. It shows that there is an infarcted patient, and in the left side is a condition when the patient arrived in emergency department. So this is interesting for us to take this case report because of prior lecture mention about vasospasm or medical complication. So this patient have a risk factor of secular aneurysm forms is hypertension and cigarette smoking, and also maybe the risk factor also cerebral blood flow pattern. In this case, patient also complain headache and focal neurological effect found in this patient. So how the mechanism of subarachnoid hemorrhage with intracranial hemorrhage mechanism happen, as we know that when the aneurysm rupture, there is a hemostatic response, a cytotoxic response, and also inflammation, and it causes brain edema, and it will lead to early brain injury. And when aneurysm rupture, intracranial pressure will increase, and as well will decrease cerebral blood flow as well. And also by increasing intracranial pressure, cerebral perfusion pressure also decrease, and it leads to hypoperfusion. When a rupture aneurysm, blood in subarachnoid space will disturb the cerebrospinal fluid drainage, and also it can cause a hydrocephalus. Hydrocephalus itself can also consecutively increasing intracranial pressure, and blood in the subarachnoid space will stimulate vasospasm, and vasospasm itself will make will lead patient to delay cerebral ischemia. On this patient, the rupture aneurysm also make extended suparenchymal hemorrhage and as well intracranial hemorrhage, that there evidence of hematome in intracranial area will give a mass effect, and also hematoma expansion will lead patient to evidence of midline shift and herniation. And herniation itself also induced by hydrocephalus, and it will finally to increasing intracranial pressure, and so on will increasing the potency of hypoperfusion and delay cerebral ischemia. So this is the mechanism why nurses should know this mechanism, because of we are responding all the clinical signs happen in the patient during hospitalization. So by this knowing this mechanism, we can take an action how nursing intervention work to avoid or to prevent any complication of subarachnoid hemorrhage. So what the nursing consideration related vasospasm happen in this case? Many expert literature said monitor for indicator of vasospasm. This is the indicator of vasospasm might be found in the patient, and in this case patient there is evidence of headache and also rise white cell count and fluctuation in Glasgow Coma Scale. The hemodynamic fluctuation also happen in this patient. What the guidelines say about how we deal with the blood pressure. This is the recommendation for medical measures to prevent rebleeding after subarachnoid hemorrhage. Say that in a patient with subarachnoids and unsecure aneurysm, frequent blood pressure monitoring and blood pressure control with short-acting medication is recommended to avoid severe hypotension, hypertension, and blood pressure variability. Already recommend that gradual reduction of blood pressure when patients are severely hypertensive. So we should collaborate to the physician when the patient, we found the patient get hypertensive above 180, but ensuring strict avoidance of hypotension. As mentioned by Mrs. Elis, that's hypotension or mean arterial pressure under 65 should be avoided. And we are, as a nurse, should closely monitoring the neurological examination while lowering blood pressure. Previous guidelines have suggested keeping the systolic blood pressure under 160 or 180. It's based on European guideline. And how nurses deal with the blood pressure issues in subarachnoid hemorrhage. It's also set in this guideline that recommendation for nursing intervention and activities referred studies. So in a patient with aneurysmal subarachnoid hemorrhage, frequent vital sign and neurological monitoring is recommended for detection of neurological change and prevention of secondary cerebral insults and poor outcome. So the highlight is how nursing deal with hemodynamic fluctuation, already stated in this guideline that we should monitor blood pressure frequently. This is the hemodynamic fluctuation of the patient, actually with the simple analytic of blood pressure variability during 16 days of hospitalization. I note that blood pressure average during 16 days of hospitalization is about 129, with mean arterial pressure is 92. But there is evidence that patient have experienced drop systolic blood pressure in the day 2 of hospitalization until 70. This is we know by retrospective evaluation and supervision about nursing activities. So we found that there is evidence of decreased systolic blood pressure. Drop under and it's recover or get increasing again about 2 hours, patient achieve 120 millimeter of mercury. Okay, this is interesting. Commonly in subarachnoid hemorrhage, blood pressure increase in the first day as a response to maintain cerebral perfusion pressure as intracranial pressure increase. But in this case, in the day 2 or second day of ICTAL, patient there is evidence of hypotensive periods. So I tried to search about this phenomenon and found the article about the Cushing's variant response of acute hypotension after subarachnoid hemorrhage. In this article says that all of us is agree with Cushing hypertension and Cushing hypertension was seen only with gradual ICPs. In contrast, a variant to the classic response also occur or hypotension may occur with sudden increasing intracranial pressure. So in this present study, hypotension sounds SHH at lower maximum of ICP values. So despite this, the cardiovascular collapse might be suggested developed in a large proportion irrespective of acute change. Such collapse of cardiovascular collapse happen without prior hypertension, and it implies a non-adrenergic etiology. So this is the issue that decreases our hypotensive period in the first hour might be occur, even though this is a rare condition, but it might be happen. So the nurses should pay attention not only about the hypertensive event, but also if there is a period of hypotension. So what the relationship about rupture aneurysm and cardiovascular collapse? Some of the article says that when the rupture aneurysm, there is hemoglobin in subarachnoid space, and it will activate the sympathetic response and elevated catecholamine. This elevated of catecholamine can causes focal myocardial necrosis. So what should we do as a nurses to anticipate this condition is by monitoring cardiac monitoring, such as cardiac monitoring should be performed in all poor grade patients and pre and post operatively, and it can be observed by observing for ST depressions of appearance, infertility, wave, and prolonged acuity interval. This is cardiovascular collapse that should be anticipated and early detected by nurses and should be reported to the physician. So blood pressure control is even more complex for subarachnoid hemorrhage, as we know that we all agree that lowering blood pressure is to decrease the risk of rebleeding, and elevating some of prior speakers said that slightly make a patient to be hypertensive. It's to prevent the delay cerebral ischemia respectively. And that's why because of there is evidence of acute hypotensive in the first hour can occur in the acute phase, even though it's rare. So the nurses should pay attention about this issue. So Mrs. Elis said that maybe the monitor of blood pressure can be performed every 15 minutes in the first hour, every first 4 hours. And what should nurses do about this issue? Hemodynamic fluctuation is closely monitor blood pressure and promoting euvolemia, closely monitor intake, output, and fluid balance, and so avoid hypotension. If hypotension evidence should be reported to physician to be treated immediately, so the patient has no to decrease the risk of delayed cerebral ischemia. This is the conclusion of this case, that subarachnoid hemorrhage is a medical condition that can lead to bleeding and delay cerebral ischemia, and hypotension in acute phase may occur and worsen brain ischemia even though happen rarely, and pathophysiological changes should be understood well by nurses to prevent complication. By understanding about physiological parameter can generate nursing intervention and guide the nurses to perform immediate actions. That's all that can I deliver. Thank you for the attention. My time, I deliver back to Bu Enny. Thank you.
Yeah. Thank you very much, Nurse Risqi. It's very wonderful presentation from you. So I think the nurses have important role, how to prevent vasospasm, how to prevent the increase of intracranial pressure, and also how to prevent rebleeding and also other complications. So the nurses have responsibility to closely monitor hemodynamic, monitor the neurological status like GCS, pupil, and also motoric function, and also NIHSS. So we also to monitor the severity of stroke. Thank you for two speakers, and may I inform to all of you that National Brain Center Hospital actually have about 4,000 stroke a year, and about 200 subarachnoid hemorrhage. We also have 250 bed capacity, and also we have about 8 neurosurgical, and we have 4 kinds of intensive care. So we have neuro critical care, so with patient with mechanical respirator, and then we also have PACU, post anesthetic care unit, and then we have stroke care unit, it's special for stroke patient, and the fourth we have high care unit. So we invite questions from Professor, Prof Kato, Prof Asra, and Dhanya.
Am I audible, ma'am?
Maybe we can invite two commentators, please. So Dr. Liew.
Yeah, Prof Liew from Malaysia.
Thanks. First of all, I would like to congratulate both nurses who presented today. They have done very extensive work and evidence-based, and I congratulate both of you. And probably I will ask Ms. Elis first question regarding rebleeding. I believe that you have need to monitor, especially those with EVD, the concentration of the blood in the EVD is. Do you have any form of measurement or in terms of visual measurement of how severe is the initial blood in the EVD when you want to diagnose rebleeding, especially patient with sudden onset of worsening headache? Do you have any way in your nursing documentation to show the concentration of bleeding within the ventricle, and to say that now this is a new fresh blood in the EVD, for example? Do you have any recording on that? My second question for Elis, probably, I would like to know that you have mentioned that the prevention of pain is important, management of pain, and you have pain scoring. How fast, how aggressive do you think the pain control should be carried out in a patient with subarachnoid hemorrhage, especially before clipping management? And probably I can ask straight to Risqi, which have done a very good presentation. And in your patient, I have two questions, Risqi. You have shown the patient post-operatively having infarction, and however, patient was discharged in 14 days, and the patient still have a pain score of 3 to 4 upon discharge. Do you worried about vasospasm still ongoing in this patient? Because usually patient with extensive subarachnoid hemorrhage, we tend to keep the patient longer in hospital, especially in the so-called the period of vasospasm of 21 days. So what's your opinion? Should this patient be kept longer in the hospital because patient still symptomatic? My second question, Risqi, do you think that where the patient should be observed, especially when you think that the hypotension is so critical, it can happen any point of time? And I believe this patient pre-operatively and even within the first week, patient should be observed in a clinical, a high dependency unit at least, not in general ward. What's the current practice in your hospital, and what is your recommendation in terms of observation, where the patient should be observed and for how long? Thank you.
Yeah, thank you, Prof. Liew. Nurse Elis maybe will answer the first question from Prof. Liew. How do you know, how do you record on the medical record about the early sign of rebleeding of the patient, such as from the EVD?
Okay, thank you, Prof. Boon Seng Liew tadi. In my hospital, the nurse can monitor the neurology sign to see if there are signs of intracranial increase resulting from rebleeding. The nurse should documentation about GCS and pupillary response and motoric response. And in the EVD, we can look how much bleed in out in buret, like that. And then buret sheet, buret ya, Bu. And then we can look the sign, the other sign of a clinic patient, like that. Thank you.
Prof. Liew, usually we also record the volume of production of fluid and then also the color. After that, maybe so we record on the medical record of the patient. Gitu ya, Elis ya?
Yes, sir.
Okay, the second question is to how to control the pain control management before surgical. Yeah.
Ibu can help me to translate.
Iya, gimana?
Yeah. I'm sorry, I speak in Bahasa, and then Ibu Enny can translate in English.
I think Prof. Liew also know in Indonesia. Okay.
Tadi Bu terkait dengan monitoring nyeri sebelum dilakukan tindakan pembedahan
Dan mengontrolnya.
kontrolnya.
Dan mengontrolnya bagaimana supaya tidak nyeri.
Ya, baik. Tentunya kita pada saat menerima pasien dengan tadi ada SAH, kita tanyakan skala nyerinya di angka berapa, skala nyerinya, lalu kemudian kita pun mendokumentasikannya dalam dokumen keperawatan, documentation keperawatan kita. Dan apabila sudah dengan kita kolaborasi dengan dokter dengan pemberian analgetik, lalu memang tidak memberikan respon yang baik, lalu kita juga melihat apakah ada tanda-tanda peningkatan tekanan intrakranial. Itu menjadi fokus utama, poin utama ketika kita consult atau konsultasi dengan bagian neurosurgeon seperti itu. Jadi pada dasarnya nyeri jika diiringi dengan adanya tanda-tanda peningkatan tekanan intrakranial, maka sudah seharusnya to consult ke neurosurgeon. Bu, can translate, Bu?
Yeah, so when nurses receive the new patient with subarachnoid hemorrhage, so the nurses have to monitor the pain scale and then collaborate with the doctor. Also, the nurses have to monitor is there any sign or symptom of intracranial pressure. So consult the doctor again. What the medicine to provide to the patient, like the painkiller. It's enough, Prof. Liew?
Yes,
Bu Enny,
yes.
yeah,
I think the most important point that she mentioned, if a patient doesn't relieve from the pain, we need to see, what's the ongoing that happening. I think it's very good answer from her. Thank you. Terima kasih.
Sama-sama.
yeah. Bu Enny, I have experienced my comments about the pain.
Please. Okay, please.
Dr. Liew, sometimes in the emergency department, general physician late to start give a painkiller, and sometimes also painkiller given only by 500 milligram of paracetamol. But we are as a nurses should identify. Of course, all the patient with subarachnoid hemorrhage evidence will fill up pain because of detectable of irritation of the meningen. So we also reminding all the nurses that pay attention about the hemodynamical. So if the patient irritable, the patient increase in heart rate. Sometimes patient don't complain about this headache because of decrease of level of consciousness, but we are wondering, is the patient have a headache, severe headache? So sometimes we collaborate with doctor and suggest given more or extra painkiller. So sometimes it's missing to pay attention about the pain, Dr. Liew.
Okay.
That's all.
Yeah. And the
Maybe Risqi, you can answer the two questions.
Yeah. Okay,
please.
Dr. Liew. So yeah, this is interesting. Sometimes, as mentioned by previous speakers, that vasospasm can occur until 21st hours since itself, but the patient already discharged about 16 days. I think the neurologists have clinical considerations because of the patient, the clinical condition patient is improved, GCS is compos mentis, and all the clinical signs is show in the good condition. And also patient prescribe Nimotop orally to continue until the next week. And also nurses should give an education how to family detect it and know about the signs of deteriorating during at the home. So that is the important how we educate and what should family do if the evidence of deterioration exists. So patients should be brought to the emergency department to be evaluated more. And also why 16 days actually in our hospital, the clinical pathways about 15 to 25 days of hospitalization for subarachnoid hemorrhage. But also there is issue of national insurance, health insurance coverage that we should cost effective treat the patient. So I think this is a consideration when the patient discharged before 20 days of hospitalization. That is the first question. And also the current practice of how frequent patient being treated in the hospital. So for all the subarachnoid hemorrhage for the acute phase, always mandatory to be treated in stroke care unit. Stroke care unit in our hospital is high care level of stroke unit. So the observation just like an intensive care unit, but patient without mechanical ventilator, but frequent of monitoring perform hourly. So until the condition is stable. Maybe before securement by surgical clipping or interventional coiling, patients still treated, and after post-operative, also after the being treated in neurocritical care unit, after extubated, patient continue to stroke care unit for intensive monitoring. But this patient actually, for this patient, 10 days observed in the intensive stroke care unit for 10 days. That's average days for the patient of being observed during acute phase before or after securement procedure. That's all, Dr. Liew.
Thank you very much, and congratulations, Dhanya.
Thank you.
Okay, thank you, Prof. Liew. Thank you, Risqi. Dhanya, have you
Good evening.
comment?
Good evening, ma'am. Am I audible, ma'am?
Yeah, I clear.
Yeah, sure.
Yes.
Thank you for inviting me in this wonderful event, and thank you all the organizers for inviting me again. And ma'am, Elis have given a detailed and comprehensive account regarding the role of nurse in all phases of nursing care, like the preoperative and intraoperative. I'm very glad that she followed the nursing process approach in describing the nursing care. So actually what she meant is the continuous assessment and close neurological monitoring is actually very crucial from the part of the nurses in detecting complications like the delayed cerebral ischemia and rebleed and hydrocephalus and seizure. And also she had given a detailed account how to provide the care in intensive care units, starting from the positioning and also monitoring the medicines, vital signs of the patient and everything. And also she once again actually signifies the importance of pain control in reducing the neurological events of the patient of experiencing subarachnoid hemorrhage. And regarding the presentation of Mr. Risqi Rakhman, and he followed a highly integrated approach, I should say, system-wise examination of all the presentation of all the symptoms experienced by the patient, as well as a nice comparison between what we expect in clinical scenario and what is actually written in books. And this kind of presentations are really making nurses update regarding the knowledge. They can means the nurses can update the knowledge and they can refresh their knowledge so that they can use this evidence-based research evidences in translating them into practice. And the events were well explained in chronological fashion, and the clinical course was very clear. And and I should once again thank you all the presenters for giving us a detailed description of their case studies. And there is one simple question like that. Madam told that the long-term anticonvulsants are avoided in aneurysm patient experiencing subarachnoid hemorrhage. Ma'am, could you please explain a little more regarding why we are avoiding long-term anticonvulsants in patients experiencing subarachnoid hemorrhage? Thank you, ma'am. Thank you, sir, for the wonderful presentation once again.
Okay, thank you, Dhanya. So maybe Elis with answer on the long-term nursing care. Yeah, Dhanya. So what's your question? Sorry.
Was, why we are avoiding long-term anticonvulsants. Ma'am told there's a brief period we can use anticonvulsants to protect the brain from the neurological complications like the delay introducing the vasospasm and all. But ma'am told that it is actually prohibited to use anticonvulsants in a long-term fashion.
Okay. Maybe Elis or Risqi will answer it.
Yeah, maybe I'd start to answer about the issue of using anticonvulsants medication to prevent seizure, as mentioned by the guideline that prevention seizure prophylaxis prophylaxis, not recommended long term. So I think it's only considered in the acute phase, and also I think we should investigate the potential of seizure happen. Maybe it's because of ischemia or maybe increase in intracranial pressure. I think if the patient, the underlying causes and pathological causes well treated, the seizure is rare happen, and I think we should educate the patient how to know the sign of seizure and what should they do if the patient present seizure at home. Maybe it's going to develop in status epilepticus, which kind of seizure that's emergency, with kind of seizure that should be observed at home. Maybe this is the important long-term care of the patient, and nurses can pay attention about it. And also I have a search in literature. Most of the patient long-term problem is a headache. Headache is also existing about 3 to 6 months after subarachnoid hemorrhage patient coming to our outpatient, still complaining a mild headache. And the one complication post subarachnoid hemorrhage also decline in a psychological condition. Patients sometimes develop dementia or maybe declining in neuropsychological. So their evidence recommendation for rehabilitation patient also should be given the patient to exercise, to memory training, to I think prevent the neuropsychological deficit. Maybe it's based on my experience when I working as a nurse treating subarachnoid hemorrhage, Dhanya. Maybe we always will comments more.
And also, Dhanya, so maybe the nurse responsibility, including educate the patient and family when discharged, and also in my hospital now we have a home care program, so the nurses can just visit or to take care of the patient at home. So I think that we as nurses we have to know about anything about subarachnoid hemorrhage, and that how to take patient at home, and also we have to educate the patient and family before discharge.
Thank you, ma'am. Thank you, sir.
Thank you.
Thank you, Dhanya.
Maybe is there another question or comment?
Basically, we can see the matron E. So you
Yeah,
make some hi, how are you?
I'm sorry, Prof.
Welcome
Hi,
back.
Matrani. How are you? Long time.
How was
I
Tanzania?
was late from the airport. I straight joined the webinar once I reached home just now. I think it's a long session. It's very informative and very interactive. I think we should call upon Professor Yoko Kato to give us a few words before the closing.
Oh, yes. Okay, thank you so much. So the two nurses, the presentation was the excellent. And I think the last question from her, we use anticonvulsant drug till day 14 and to finish vasospasm period. But if the patient does not have any intracranial hemorrhage, we do not continue use of the epileptic agent, I think. And also very important thing is, as a nurse, please don't miss the sign of the patient deterioration. That is the start of the vasospasm. Vasospasm is very, very important point to treat. And also always you should keep the perfusion pressure. That means is keep the blood pressure and not hypovolemic something. So just hemodynamics is very important for treatment of the vasospasm. Thank you very much. It was the excellent talk. Of course, the Asra is a super excellent talk. I think he will be the president of the two big congress. So Thank you very much for Asra for teaching us.
Thank
Thanks
you,
so
Agus.
much. Thank you.
Okay, thank you very much, Prof. Asra and the rest of the speakers, the session chairs and the commentators. We have a very interactive session. I think nurses to play a very important role in nursing this type of patients, subarachnoid hemorrhage, to detect especially vasospasm. So I think with that, we'll see you again in the next webinar, end of June. So bye-bye, everybody. Thank you very much.
Thank you. Bye-bye.
Thank you very much,
Bye.
Professor.